Hi, my name is Suzuka. I'm a third year med student, and I'm just recording these videos to help me and hopefully other people review for their COMATs. So this one's about surgery. I just took the COMAT outline and some questions over TrueLearn to try to consolidate some of the information that I found. So starting off with breast conditions, the benign breast masses are listed here. So a mass that fluctuates with the menses and has acoustic enhancement on the ultrasound. This usually happens in premenopausal women and is usually a fluid-filled round mass that is going to be a simple cyst. The management for this is aspiration if it's symptomatic or painful, and reassurance if it's asymptomatic. If you have a mass that is highly mobile, firm, and painless, also estrogen responsive, growing with increased exposure to estrogen, this is going to be a fibroadenoma. This would involve the management for this would involve conservative monitoring in young patients and then do an ultrasound or core needle biopsy to confirm the diagnosis. The next mass is it's not like much of a mass, but it just has more of a diffuse nodular texture in the breast without like a single discrete mass. And it is multifocal breast changes with fibrous tissues and small cysts that are very common in the reproductive years. This is just going to be fibrocystic changes. The management for this is going to be reassurance and supportive bra. And then if it is painful, using NSAIDs for the mastalgia. The next mass is going to have bloody or serosanguinous nipple discharge from a single duct. And this is not going to be a palpable mass. This is a benign fibrovascular tumor, and this one is going to be the intraductal papilloma. The treatment for this is going to be duct excision of the affected duct, and then you would want to verify the pathology because it is leaking bloody discharge, which is suspicious. The next condition is going to have thick green or brown pasty discharge. It might present with nipple retraction and a tender mass in older women. This usually happens in multiparous postmenopausal women. This condition is mammary duct ectasia. The treatment is going to be reassurance and then warm compress or antibiotics if a secondary infection occurs. If it's very severe, surgical excision might be warranted. Continuing on, the next condition is going to present in a lactating mother with localized erythema, warmth, fever, and it is going to be an infection of the breast tissue. That is going to be acute mastitis. Most commonly, this is via Staph aureus and happens during breastfeeding. So the treatment for this is going to be dicloxacillin or cephalexin, and it's recommended to continue breastfeeding or pumping to maintain the drainage. The next condition is going to present with a fluctuant mass that presents with surrounding induration, systemic fever, and non-resolving mastitis. This is going to be a localized collection of pus, and it can present as a complication of the acute mastitis. This is going to be a breast abscess. The management for this is going to be ultrasound guided needle aspiration or incision and drainage, depending on how big that is, and then also give the patient antibiotics. The next condition is going to be presenting in a woman that had prior breast trauma or surgery, and then on histology, it shows, or on the mammogram, it shows oily cysts and the foamy macrophages. So that would be on histology. And this is a benign inflammatory lesion that's caused by the saponification of fat. So that would be fat necrosis. And the management for this would be reassurance after the biopsy rules out malignancy. Our last one on this page is going to present with microcalcifications on a screening mammogram in an asymptomatic woman, and the biopsy shows proliferative atypia. So it presents with atypical histological features, and it's not exactly cancer, but this condition would be atypical hyperplasia. So the management is excisional biopsy to rule out concurrent DCIS or cancer and then monitor very closely. Moving on to breast cancers. And so the pre-invasive and the in situ lesions. We just talked about the atypical ductal hyperplasia. The next one is going to be a cluster of microcalcifications with no palpable mass. So very similar. Um, and this is going to be DCIS or ductal carcinoma in situ. And this is what you want to make sure you rule out when you're suspecting the atypical ductal hyperplasia like we were talking about. So some options for treatment for this include lumpectomy with radiation, which is considered breast conserving therapy, or a total mastectomy. A sentinel lymph node biopsy is usually unnecessary unless a mastectomy is required or it's a high-grade lesion. The next lesion is going to be an asymptomatic incidental finding that is found on core biopsy for a different lesion. There's no calcifications, and this is going to be an non-invasive proliferation of cells in the lobules due to the loss of E-cadherin. So that would be LCIS, lobular carcinoma in situ. The treatment for this would be observation and risk reduction, and bilateral mastectomies would only be required in high-risk patients such as BRCA1 and 2 mutation carriers. The next condition is going to present with eczematous or scaly plaque on the nipple with persistent burning and itching. And this is representative of an interdermal spread of the malignant adenocarcinoma cells into the nipple complex. So this is going to be Paget's disease of the nipple. The treatment for this is a central duct excision or lumpectomy and a single lymph node biopsy, depending on how the underlying tumor looks. So now moving on to invasive carcinomas. The first one is going to present as a hard, fixed, solitary mass with skin dimpling and nipple retraction. And mammogram will show a dense and spiculated mass. This is also the most common subtype of invasive breast cancer. So this will be invasive ductal carcinoma. So management for this, again, it can be the breast conserving therapy of lumpectomy plus radiation therapy, or a full mastectomy with the single lymph node biopsy and then adjuvant hormonal therapy. The next cancer is going to be a subtle ill-defined mass or distortion with high rate of bilateral breast involvement. And this is also going to be due to the loss of E-cadherin, like we were talking about earlier. So this will be invasive lobular carcinoma. The treatment for this would be lumpectomy or mastectomy with a single lymph node biopsy. So it's very similar to the invasive ductal carcinoma that we were just talking about. The next condition is going to present with a peau d'orange appearance, and it should be suspected when the diagnosis of mastitis is suspected, but the patient fails to improve on antibiotics. So this condition would be inflammatory breast cancer. And the treatment for this would be chemotherapy first, so neoadjuvant, and then a modified radical mastectomy and post-mastectomy radiation therapy. This one is very aggressive, so the treatment is also aggressive. The next condition is a fleshy, well-circumscribed mass in a younger BRCA1 carrier that mimics fibroadenoma. And this is medullary carcinoma. This one is a lot more rare, and the treatment is very similar to the IDC and the ILC. And then here are a bunch of the rare subtypes of breast cancer. The first one is a rapidly growing leaf-like mass. Sorry, a rapidly growing large mass that presents leaf-like on histology. And this one's going to be a phylloides tumor. Um, an elderly woman presenting with a soft gelatinous mass with clusters of the malignant cells floating in extracellular mucin pools would be a mucinous carcinoma. And then a small spiculated mass on a screening mammogram with biopsies showing the teardrop tubules would be a tubular carcinoma. And then the last one, a patient with prior radiation therapy or chronic lymphedema, now presenting with a malignant vascular neoplasm, would be angiosarcoma. So again, these are a lot more rare, so you can read the details, but I don't know how high yield that portion is. Okay, so management is going to be the age is going to direct the initial imaging. So if a patient is over 30, they get a mammogram and core needle biopsy, really like regardless of what the mammogram suggests. Um, and under 30 gets an ultrasound. And from there, the ultrasound will direct findings as listed in that second paragraph there. But again, this is going to be the management of a breast lump and not just like this is like different than the screening mammogram. So going back to the imaging findings, so after an ultrasound, if the ultrasound is suspicious, then the next step is core needle biopsy. If the imaging shows cystic findings, but the patient has symptoms and wants that resolved, then the next step is a fine needle aspiration. And then if it's cystic and the patient is asymptomatic, then just observation. We kind of went over this a little earlier, but breast conserving therapy would be lumpectomy plus radiation, and that would work on smaller lesions versus a large lesion would require mastectomy. And a single lymph node biopsy, I think that's misspelled, would be indicated before doing a full axillary lymph node dissection to avoid complications like lymphedema. Okay, the next topic is going to be hernias. So in terms of general management, so incarceration of a hernia is when the bowel gets trapped and it can't go back in. That would be a situation of doing an urgent repair versus strangulation is now that incarcerated bowel gets the blood supply to it cut off, and that is going to be an emergent repair situation. And then with mesh, it's contraindicated if there's an infected surgical field. And then with complicated or a lot of the elective cases, physicians would use the CT to see where the defect is and how um, to operate most effectively. So a lot of different types of hernias. The first one that we'll talk about would present as an infant or a child with a mass down to the scrotum, and that increases when they cough. And is going to be lateral to the epigastric vessels, and it's due to a patent process vaginalis. So all those clues would point you to an indirect inguinal hernia, and the management for that would be elective repair. A older male increasing mass when they cough that has the hernia medial to the epigastric vessels through the Hesselbach's triangle would have a direct inguinal hernia. A patient with a persistent bulge after fixing one of the hernias leads to a suspicion of there being an indirect and a direct hernia on the same side, and the name for that is the pantaloon hernia. Um, so a hernia that has severe localized pain and skin changes without small bowel obstruction symptoms. and the definition for this is that part of the intestinal content is herniated, but the intestine is still patent, so that's why there's no obstruction. That would be a Richter hernia, and the management for this would be an urgent repair. Um, a hernia that presents with unexplained, now small bowel obstruction or painless bleeding with the mass. And the one that contains the Meckel's diverticulum would be the Littre hernia. Um, a hernia basically that contains the appendix, so would present with appendicitis-like symptoms along with hernia symptoms, is an amnion hernia. And an elderly female presenting with small bowel obstruction despite no prior surgery and a groin mass below the inguinal ligament would be femoral hernia. Continuing on, a hernia that has a retroperitoneal organ that's incorporated into the hernia sac. On one of the vignettes I saw, I think it presented with urinary symptoms because the bladder got involved. That would be a sliding inguinal hernia. And one management thing is that the hernia contains the GI contents, so beware of that during hernia repair. A hernia with intermittent pain or bulge at the lateral abdominal wall, with the hernia being through the linea semilunaris, is called a Spigelian hernia. A hernia that presents with the Hauschip-Romberg sign, which is medial thigh pain, when there is hip internal rotation and extension, is an obturator hernia. A hernia that goes through a previous incision is an incisional hernia. A hernia through a peritoneal defect, but not through like any of like the fascial layers, is going to be an internal hernia. This is more common in bariatric surgery patients. A One of the hiatal hernias that presents with GERD and where the G junction herniates upward would be a sliding hernia. And the hiatal hernia that presents without GERD and with the gastric fundus herniating out of the diaphragmatic hiatus is a paraesophageal hernia. And then just the management tips on this. The sliding hiatal hernia would be medical management, while a paraesophageal would be surgical repair. Continuing on, so a midline mass due to a linea alba defect would cause an umbilical hernia. Management for this, if it's a child, then reassure the patient and the parents because it'll probably close up on its own versus an adult would require surgical repair. Now two types here. The Bochlodek is the posterior defect and the Morgani is the medial defect, but both of them are going to be herniations through the diaphragm, so that's a diaphragmatic hernia. I think the Bochlodek one is more severe, and in either you'd hear bowel sounds in the chest cavity. A patient that presents with blunt trauma and then the X-ray showing loops of bowel or an NG tube in the chest would have a traumatic diaphragmatic hernia. And this one happens more on the left side because there's no protection of the liver. A patient presenting with a firm, non-tender mass with familial adenosis poli or trauma history, having now like fibroblast proliferation, would have a desmoid tumor. And the management for this would be a wide excision with radiation versus a soft mobile mass with adipocyte proliferation, which is be a lipoma. And the management for this is reassurance. Okay, next we will talk about endocrine conditions. So starting with the thyroid and the parathyroid conditions, the first four are going to be different cancers. So if a patient presents with orphan antinuclei and plasma bodies on the histology and is described as having the most common thyroid cancer associated with radiation exposure, this would be a papillary cancer, papillary thyroid cancer. Um, a patient who is a middle-aged female um, presenting with a thyroid mass. This one's the second most common one, and needing and this one is going to be follicular. One thing to know about the follicular thyroid cancer is an FNA won't work um, because the physician needs to see the capsule and if there is invasion through the capsule. So that's like a diagnostic difference. Okay, and then a patient presenting with high calcitonin, amyloid deposits, or apple green, the birefringence, or flushing, maybe has MEN2, and this is described as a tumor of the C cells, has medullary thyroid cancer. Management for this, um, the patient needs to be screened for pheochromocytoma before they get taken to surgery, and then the resection happens with a central neck dissection. Now, the fourth type of thyroid cancer presents as a hard, fixed neck mass in an older person, and it is known to have a bad prognosis. This would be anaplastic thyroid cancer, and most of the time, this would be palliative chemo. Now, moving on to the parathyroids. So, um, any high parathyroid hormone due to autonomous secretion or response to hypocalcemia or hyperphosphatemia would be hyperparathyroidism. There's primary, secondary, and tertiary. Surgical resection would be good for primary and tertiary versus medical for the secondary. Um, the next condition would have the Chopstick sign, which is the tapping on the cheek, causes a twitch of your like paraorbital region, or the Trousseau sign, where inflating a BP cuff causes carpal spasm. Um, these would be signs of hypocalcemic tetany, and this is neuromuscular excitability due to decreased calcium. So the treatment for this is IV calcium gluconate. A patient presenting with low calcium, phosphate, and magnesium with normal PTH after treatment of hypocalcemia. This could be hungry bone syndrome, which is just rebound hypocalcemia and hypophosphatemia due to bone remineralization after they were given some calcium. So suspect this in like a patient that has sustained low calcium even after treatment. So the treatment for this is give them more calcium and vitamin D. The next condition would present in a patient who has episodic headache, sweating, and tachycardia. And the key here is episodic. This would be signs of pheochromocytoma, and this is due to adrenal medulla overgrowth. Good management tip is give the alpha blocker before the beta blocker before surgery. So it would be alpha blocker, beta blocker, then surgery. And the reason for that is because if you don't give the alpha blocker first, then there is unopposed alpha stimulation, which will lead to vasoconstriction and like super bad hypertension. So that's why you're trying to avoid that and why you give the alpha blocker first. And yeah. A patient presenting with resistant hypertension with hypokalemia might have primary hyperaldosteronism, and that's just any autonomous secretion of the aldosterone. The diagnostic steps in these is so you'd confirm with an oral sodium load, which should decrease the aldosterone in a normal healthy patient. Then you do an adrenal CT followed by the adrenal vein sampling. And then if it's found to be a unilateral case, then adrenalectomy would be the treatment versus a bilateral case would need aldosterone antagonists to treat. Now a bunch of like pancreatic endocrine tumors. Um, the first one is going to present with hypoglycemia, and it's just like it's basically just that. It's the like the Whipple's triad, which is like the different versions of the hypoglycemia. And this is going to be just an oversecretion of insulin. The condition that Zollinger-Ellison is associated with would be a gastrinoma. Treatment is resection with proton pump inhibitors. A patient presenting with watery diarrhea, hypokalemia, achlorhydria would have the VIP-OMA. A patient presenting with new onset diabetes, necrolytic migratory erythema, weight loss, DVT, that would be glucagonoma. And for both of those, it would be the treatment for those would be resection and give them octreotide, which is a um, somatostatin, I want to say it's an antagonist, but don't quote me on that. Um, the somatostatinoma um, would present with gallstones, steatorrhea, and diabetes. And the treatment for that would be resection. And the carcinoid tumor would present with flushing, watery diarrhea, and right heart valve issues. Um, Let me look that up. Mhm. Okay, so sorry, octreotide is a somatostatin analog. So it mimics somatostatin and tries to suppress the levels of VIP, glucagon, or whatever that carcinoid tumor is secreting. So there we go. Um, Pituitary conditions. So an infarct to an existing adenoma. This condition would be apoplexy, and the management is IV steroids and cranial decompression if needed. Um, Necrosis following hypotension or postpartum hemorrhage is going to be Sheehan syndrome. And the management for this would be hormone replacement, whatever the like if it's very severe, then all the hormones that the pituitary was making would have to be replaced. A classic vignette for this would be somebody postpartum and they're unable to lactate, and that's because the prolactin is not getting released. A patient presenting with bitemporal hemianopsia, maybe getting symptoms of over secretion of prolactin or growth hormone or cortisol. That would be an adenoma. The treatment for these, if it's a prolactinoma, the treatment first line is cabergoline or bromocriptine, which are dopamine agonists that will try to suppress prolactin secretion, versus a somato or corticotroph would be transsphenoidal resection of the tumor itself. The next tumor is of the Rathke's pouch, and this would either be in a young patient, like a kid, or an old patient, and presents also with bitemporal hemianopsia. Um, and is described as a calcified cystic mass. This would be craniopharyngioma, and the treatment for this is resection and radiation. Now, different, what is it? Familial syndromes. The first one is going to be the three Ps. So pituitary adenoma, parathyroid hyperplasia, and pancreatic tumor. That would be MEN1. Um, the next one would be parathyroid hyperplasia, pheochromocytoma, and medullary thyroid cancer, and that is going to be MEN2A. And I think it got cut off here, but this next one would present with pheochromocytoma, medullary thyroid carcinoma, and mucosal neuromas or Marfan syndrome, and that would be MEN2B. So MEN 2A and 2B present with the same gene defect, which is the RET gene. Okay, now moving on to the testes condition. I think the highest yield one, because I keep seeing it, is going to present with sudden severe pain with an absent cremasteric reflex and high riding testes. That is going to be testicular torsion. So Doppler can be used to confirm, and then detorsion with bilateral orchopexy, so surgical like pinning of the testes to the surrounding wall is going to be the management. A patient presenting with the blue dot sign and just the twisting of the appendicular part would be a testicular appendix torsion. This one is going to just have reassurance and NSAIDs. Um, a patient presenting with fever and infection symptoms with dull pain and a positive Pren sign, which is when you raise the testicle up, it alleviates some of the pain, would be epididymitis, and that is going to be due to an inflamed epididymis, and it is going to be treated with antibiotics. Now, two conditions that what the first one transilluminates and is like a separate mass from the testicular pole due to a retention cyst of the epididymis head is going to be a spermatocele versus transillumination with fluid in the tunica vaginalis is going to be a hydrocele. And then the other one, what feels like a bag of worms that increases with the Valsalva maneuver and is due to dilated veins and happens more on the left side, is going to be a varicocele. The treatment for all of those is to observe. Okay, the next section is GI and nutrition. So, first talking about the different vitamin deficiencies. Presenting with blindness, the Bitot spots, and poor epithelial growth, that would be vitamin A. Um, Presenting with rickets, osteomalacia, and possibly secondary hyperparathyroidism is vitamin D. Hemolytic anemia or neurological deficits is going to be vitamin E. A prolonged PT or an INR is going to be vitamin K. Dry or wet beriberi, Wernicke-Korsakoff syndrome is going to be thiamine, B1. And a management tip here is to give thiamine before dextrose in resuscitation protocol. Presenting with a facial rash, I'm sure it like presents with other symptoms too. I think some of them are like the angular, like chelosis and things. But that is going to be riboflavin. Presenting with pellagra, which is dermatitis, diarrhea, dementia, is going to be vitamin B3, niacin. Presenting with peripheral neuropathy associated with isoniazid is going to be pyridoxine, vitamin B6. Presenting with megaloblastic anemia with a normal methylmalonic acid is going to be folate deficiency. I think that should say B9. I'll go fix that. And then presenting with megaloblastic anemia with neurological deficits with a high methylmalonic acid activity is going to be cobalamin, which is B12. And then finally, scurvy with the gum, hair, wound healing issues is going to be vitamin C. And I think this is like more IM heavy stuff. I don't know like how they write it, but I think the ones like more important are the ones that affect coagulation or the ones that affect like wound healing. So I think that's why it's in there. With other things like electrolytes. So if you have high calcium, that is the stones, bones, groans, psychiatric overtones. If you have low calcium, we talked about that a little earlier, the muscle spasm, so like the Chopstick and the Trousseau's sign, with perioral numbness. And one of the vignettes was mentioning about how hypocalcemia happens due to chelation by citrate during transfusion. So I think it also said that it really doesn't happen unless the liver is not working as it should. With potassium, the main concern is arrhythmias. So if you have high potassium, it will cause like peaked T waves, and then low potassium will flatten the T waves. With sodium, hyponatremia will present as lethargy, nausea, seizures. With the nutritional status, so albumin, transferrin, and weight loss are the important markers for nutritional status. And then when you're trying to resuscitate somebody nutritionally, the preferred method goes oral is best, and then enteral, like a NG or NJ tube, and then parenteral is like TPN. And then with refeeding syndrome, the patient's going to present with low magnesium, low phosphate, low potassium in a recently nutrient resuscitated patient. So it's important to replete the electrolytes while feeding to prevent this from happening because there's like a whole host of bad things that can happen, like we were talking about earlier. Okay. A patient presenting with right lower quadrant pain. So some might include like Rovsing sign, which is right lower quadrant pain um with I want to say that's like left lower quadrant. I don't know. Palpation. So like you palpate one side and then the other side gets painful. Or the psoas sign, the right lower quadrant pain with hip extension or restricted flexion, or the obturator sign, which is the right lower quadrant pain with internal rotation of the hip. That all points towards appendicitis. Um, with the antibiotics for this, um, give antibiotics pre-op and then for 24 hours post-op, which can be stretched to 3 to 5 days if it's ruptured. The next condition is an appendix neoplasm, and the management for this is going to be right hemicolectomy if the neoplasm is greater than 2 centimeters or the base of the appendix is involved, versus less than 2 centimeters without the base of the appendix involved is going to just be appendectomy. All right, so next is the motility disorders. So those include achalasia or diffuse esophageal spasms. Um, the gold standard for diagnosis for this is manometry, and the Heller myotomy can be used for achalasia treatment. Okay, the next condition is going to have a patient present with halitosis and dysphagia in an older male. And this is defined as a false diverticulum through Killian's triangle. That is the Zenker diverticulum. This can be corrected with endoscopy or open surgery. The next is going to be a full thickness esophageal tear. You might see widened mediastinum in this. This is Borhave syndrome. The important management tip is to use water-soluble contrast because if it is indeed perforated, the water-soluble contrast will not be irritating to the mediastinum. A mucosal tear in the esophagus presenting with bloody emesis, that is Mallory Weiss, and the treatment is just reassurance. Um, The two flavors of esophageal cancer are adenocarcinoma or squamous cell carcinoma. In either case, CT will be used for staging, and then the mass will be resected out. And then a congenital blind esophagus, often presenting with other bacterial anomalies, would be esophageal atresia with or without that tracheoesophageal fistula. Next, we'll talk about the conditions in the head and the neck. A stone in the salivary gland, um, and having a patient that presents with like a painful salivary gland that's worse with eating is sialolithiasis. Treatment is just to increase fluid intake. If that doesn't work, endoscopy to try to get it out. Surgery if it's over 4 millimeters big. Um, a metabolic growth of the salivary gland with painless bilateral swelling would be sialoadenosis. An infection of the salivary gland and with worsening pain and like systemic symptoms would be sialoadenitis. Um, a tumor that is most common in older people or with prior radiation exposure. This would be a salivary gland tumor, and this will present with painless unilateral swelling. Now, distinguishing between the treatments for nasal hematoma, that would be drainage, perforation would be a surgical repair, and then the foreign body would be removal. Also, hematoma is usually after trauma, and then septal perforation appears in some vignettes as associated with cocaine use. Um, a patient that presents with rupture of the middle meningeal artery and now has a lens-shaped hematoma. They might have had like a lucid interval where they fell unconscious and now like woke back up and now is drifting into unconsciousness again, would have an epidural hematoma. Treatment is emergent craniotomy. A patient presenting with rupture of the bridging veins and a crescent-shaped hematoma. Um, this would be a subdural hematoma. The people that are at risk would be old people, alcoholic people, and then infants. So with this, a craniotomy would be indicated if it's symptomatic with a midline shift versus if there's no midline shift, then measures to try to reduce the intracranial pressure. Okay, moving on to stomach conditions. Presenting with epigastric postprandial pain um, and can cause perforation, bleeding, or gastric outlet obstruction. This would be peptic ulcer disease. Management is avoiding NSAIDs and looking for H. pylori, do PPI treatment, and then if it's endoscopically clippable, then do that versus surgery. Um, a patient presenting with early satiety, vomiting, a succussion splash, often due to obstruction from peptic ulcer disease or pancreatic cancer, would have a gastric outlet obstruction. Um, a patient presenting with any of like the Vertigo, Sister Mary Joseph, Krukenberg, Bloomer shelf nodes. This would be adenocarcinoma. It does come in two flavors, intestinal and diffuse. Um, with the management portion, if this is found in the antrum, the answer is going to be a subtotal gastrectomy versus, so you'd like leave that top portion alone versus a middle or upper adenocarcinoma would be a total gastrectomy. A young patient presenting with non-bilious vomiting within the first 2 to 6 weeks of life would have pyloric stenosis, and that's just hypertrophy of that pylorus. Um, a patient that so some of the bariatric surgery complications, early complications include an anastomotic leak versus a late complication could be a marginal ulcer, an internal hernia, or something like dumping syndrome. So also with the guidelines for bariatric surgery, it's recommended for patients with a BMI over 35 or BMI from 30 to 35 with failure of medical treatment and comorbidities. Um, With the Billroth 1 procedure, that is also known as a gastroduodenostomy, and Billroth 2 is going to be a gastrojejunostomy. And that's just like anytime there's severe cancer or peptic ulcer disease that needs to be like resected and the ends need to be attached. And one complication of this is like a leak, the anastomotic leak that we're talking about. And that will present with a change in the drained fluid color. Okay, now talking about duodenum and small intestine conditions. So a patient that has epigastric pain that gets better with eating, commonly found in Zollinger-Ellison syndrome, would have a duodenal ulcer. A patient that has had sudden weight loss or trauma now has the duodenum compressed between the SMA and the aorta, has SMA syndrome. Um, a patient presenting with bilious emesis and the double bubble sign, possibly has Down syndrome, would have duodenal atresia. A patient that has some sort of like adhesion, hernia, or neoplasm, and now has um, pain and possibly peritoneal signs or lab markers like increased lactate or leukocytosis, could have small bowel obstruction. And the management for this is it just depends on how stable the patient is. If they're unstable, they go to surgery. Um, Also, if they have metabolic acidosis or the pneumoperitoneum, because that will not get better medically. A patient with the pain out of proportion to exam, so severe 10 out of 10 pain, but soft abdomen and like no rigidity, um, caused by an embolus in the SMA, has acute mesenteric ischemia. So the management steps here are do a CT angiogram first, and then surgical embolectomy, and then resection of the non-viable bowel if there's any. Um, a patient presenting with painless lower gastrointestinal bleeding or possibly intussusception would have Meckel's diverticulum, and this is due to incomplete obliteration of the vitelline duct. And the diagnostic step is the technetium 99 M scan. Um, a condition that can cause the midgut volvulus and on imaging has the cecum in the right upper quadrant with the lad bands crossing the duodenum has malrotation. So treatment or diagnosis and treatment is do an upper GI series and then the LAD procedure to free up some of those bands. Um, a inflammatory bowel disease that causes gallstones and that has transmural inflammation, where the most common site is the ileum, is Crohn's disease. Surgery is mainly indicated for if they have fistulas or infections. And then a patient presenting with megaloblastic anemia due to B12 deficiency, and has a stagnant segment of that small intestine is going to have blind loop syndrome. And then for this, the treatment is, or like the diagnosis is do a breath test or jejunal aspirate, and then antibiotics with surgical repair. Okay, large intestine conditions. With right-sided adenocarcinoma, it would mostly be anemia that's seen versus left-sided is altered bowel movements. Um, with the colonoscopy follow-up guidelines. So 1 year follow-up if there's more than 10 1 centimeter adenomas, 3 years if a single adenoma is over 1 centimeter, 5 years if there's 3 or 4 adenomas but less than 1 centimeters, and then 7 years if normal. Um, the next syndrome is going to be found in critically ill or post-op patients with a massive dilation of the cecum and the right colon without actual mechanical obstruction. And that is going to be Ogilvie syndrome. So treatment for this would be conservative and then give them neostigmine and endoscopic decompression. And it's very important to rule out an actual like small or large bowel obstruction because neostigmine would make things worse if that was present. A patient presenting with an older patient presenting with a coffee bean sign versus a younger patient presenting with the cecum pointing to the left upper quadrant. That is going to be sigmoid volvulus for the first one and the cecal volvulus for the second one. The treatment for this with sigmoid is going to be endoscopic detorsion versus cecal is going to be surgical resection. A patient presenting with left upper quadrant pain, and this is defined as I don't know if that's supposed to be left upper quadrant. I think it might be left lower quadrant, but I'll check on that. With outpouching and inflammation of the mucosa and submucosa is going to have diverticulosis, diverticulitis. Um, Colonoscopy is indicated for diverticulosis, but contraindicated for diverticulitis. Diverticulitis should get a CT abdomen with contrast. Okay. The next one is going to be a patient that had C. diff a few days, a week ago, or did recent bowel prep, has a diagnosis of ulcerative colitis, and now has acute colonic distension. A toxic megacolon is on the list of differentials there. The treatment for this is IV fluids and antibiotics with total colectomy and end ileostomy if it has perforated. Um, the next condition is associated with cystic fibrosis, presents with microcolon with distal ileal obstruction, and that is going to be meconium ileus. The next condition is going to be hypoperfusion of the colonic mucosa, specifically at 2 points, the Griffiths point, which is also known as the splenic flexure, where the SMA and the IMA meet, or Sudek's point, which is the rectosigmoidal junction, where the superior rectal and the sigmoidal arteries meet. That is going to be ischemic colitis, and that those areas have like they're known as watershed areas, and they have weaker perfusion. So that's that one. And then a patient presenting with telescoping of a proximal segment of the bowel into the adjacent segment, possibly with current jelly stool, is presenting with intussusception. In adults, the lead point for the intussusception is pathological. So in addition to resolving the intussusception with error contrast enema, it is important to look for that lead point. And I'm looking up the diverticulosis. Yeah, so it's actually the left lower quadrant that is going to be hurting. So I'll fix that on the PowerPoint. Okay, now rectum and anus conditions. With cancer, if sigmoidal cancer is found, the next step is to do CT and colonoscopy of the whole colon and measure the CEA levels, and then do the nigro chemoradiation protocol. With hemorrhoids, the internal ones are painless versus the external are painful if they're thrombosed, and the distinction is either like above or below that dentate line. The next condition would be a tear in the anoderm that presents with sharp defecation, a sharp pain on defecation, or bright red blood per rectum. That would be an anal fissure. The next one would be an acute infection of the cryptoglandular glands near the anus, and that's an anorectal abscess. The superficial version of the anorectal abscess would be a perineal abscess. An infected intergluteal cleft would be pilonidal disease. And then smooth papules due to secondary syphilis is condyloma lata. an aganglionic segment of the rectum, and delayed passage of meconium with bilious emesis. That would be suggestive of Hirschsprung disease. Okay. The next one is hepatobiliary conditions. So just as a general rule, if biliary disease is suspected, the next step is right upper quadrant ultrasound. Um, so the first condition is going to present with intermittent right upper quadrant pain due to the stone intermittently blocking the cystic duct. That is cholelithiasis and biliary colic. So cholelithiasis can be symptomatic, and when it is, it would be called biliary colic. The next syndrome presents with jaundice, hyperbilirubinemia, and is due to the compression of the common hepatic duct by the gallstone, and that is known as Merizi syndrome. The treatment is ERCP followed by cholecystectomy. The next condition presents with Murphy sign, fever, leukocytosis, and now it's constant instead of intermittent right upper quadrant pain. That is cholecystitis. Um, the next condition presents with jaundice and a dilated common bile duct and is known as a stone in the common bile duct. That is cholelithiasis. Treatment here is do an ERCP followed by a cholecystectomy. Patient presenting with a Charcot triad, which is fever, um, that would be fever, right upper quadrant pain, and jaundice. Um, and is defined as an infection of the gallbladder and the main bile duct, is presenting with cholangitis. Some enteric organisms that infected include Enterococcus or Klebsiella or E. coli. And the treatment for this is antibiotics and an ERCP. Mm, okay, I'll look at that ERCP too. Okay. The next one is going to be present in critically ill patients. And this is a distended gallbladder without stones. That is acalculous cholecystitis. And the treatment for this is percutaneous cholecystostomy because they're pretty sick, so they shouldn't be like getting surgery right that moment. So you just drain it and then um, do a cholecystectomy if they're once they become more stable. The final one on this page is going to present with painless jaundice, weight loss, high CA 19-9, and the CEA with a normal common bile duct size and dilated intrahepatic ducts. This is going to be cholangiocarcinoma. And the treatment for this is going to be the Whipple procedure. Yeah. Let me look up the treatment real quick for cholangitis. Okay, yeah, so that is correct. Yeah, so it's antibiotics followed by the ERCP to just like drain some of that blockage caused by the infection of the main bile duct. Okay, continuing on, this one will present with a regular triad, so that is with a small bowel obstruction, pneumobilia, so air in the biliary tree, and an ectopic stone due to gallstone blocking the small bowel is going to be gallstone ileus. A patient presenting with severe epigastric pain and high lipase, along with abnormal liver function tests, is going to have gallstone pancreatitis, and that's when a stone in the ampulla of Vader blocks the pancreatic duct. A patient that had recent opioid use and now has recurrent right upper quadrant pain, that might be due to a sphincter of Oddi dysfunction. A patient that is 1 to 2 weeks post cholecystectomy with fever, distension, mild peritoneal signs could have a postoperative leak of bile in the peritoneum. And then a patient presenting with original right quadrant pain that never went away despite having the cholecystectomy done could have post cholecystectomy syndrome. So that could be due to the procedure, or it could be due to like a different underlying cause. So, like for example, if they had like peptic ulcer disease, um, and they had gallstones also, and you thought that removing the gallstones would resolve the issue, but now it doesn't. Now it's time to look at the peptic ulcer disease. So that's what that means by solve the underlying cause. Okay, now liver conditions. Three types of abscesses. The first one is a polymicrobial infection from either a biliary disease or an abdominal infection. That is a pyogenic abscess. A infection due to Entamoeba histolytica with travel history in the vignette is going to be an amoeba abscess. And then a patient that has sheep or dog exposure with eggshell calcifications on imaging would have an echinococcal abscess. Um, a young female that has a benign vascular tumor, that is a hemangioma. A young female that has a non-neoplastic vascular malformation that looks like a central scar would have focal nodular hyperplasia. And then a young female on OCPs that has a benign hepatocyte proliferation has an adenoma. A older patient with cirrhosis that has lighting up of the lesion on both the arterial and the venous phase with high AFP has hepatocellular carcinoma. And then a patient presenting with a classic bronze diabetes due to excessive iron absorption and accumulation has hemochromatosis. Um, Now, the pancreas and spleen conditions. So, a patient presenting with epigastric pain, amylase, and high lipase has acute pancreatitis. The two most common causes are alcohol followed by gallstones. Two complications. There could be pancreatic necrosis, and that usually happens within a week, or pancreatic pseudocyst, which happens in a month. IV fluids, pain control, early nutrition are the treatment plan. A patient presenting with recurrent epigastric pain, exocrine, endocrine insufficiency, and progressive destruction due to the chronic inflammation, um, could have chronic pancreatitis. A patient presenting with the Courvoisier sign, which is painless jaundice, or the Trousseau syndrome, which is the migrating like erythema lesions, or a high CA 19-9 with dilated common bile ducts and intrahepatic ducts is an adenocarcinoma. I got tricked on this. So if the patient has dilated common bile duct and intrahepatic ducts, that would be pancreatic in origin because the pancreas is distal to both of those structures versus in cholangiocarcinoma, the common bile duct size is normal, but the intrahepatic duct is going to be dilated. And the treatment for this is Whipple procedure. A baby with abdominal distension, presenting with a ring of pancreatic tissue along around the duodenum, has an annular pancreas. A patient that has recurrent pancreatitis, um, despite being young, that could be due to pancreas devisum, which is the unconnected, like dorsal versus ventral halves of the pancreas. Treatment for this would be do an MRCP to confirm that that is the etiology, and then ERCP to treat if that is possible. So, yeah. And then some post-splenectomy infections. This will be due to encapsulated organisms, three in particular, are strep pneumo, Neisseria meningitidis, and Haemophilus influenza. So treatment for this is vaccinate ideally 2 weeks before the splenectomy. If it was an emergent splenectomy due to like trauma or whatever, then vaccinate 2 weeks after. Okay, the next section is the integumentary and the MSK section. So with the skin, our first condition presents with painful purulent nodules with draining sinus tracts. And this is due to occlusion of the apocrine sweat glands. This is going to be hidradenitis suppurativa. Treatment is clindamycin, tetracycline, or surgical excision. The next condition is due to either Pseudomonas or Staph aureus infecting the hair follicles. and that is follicular pyoderma. Next condition is gonna have erythematous tender linear streaks due to bacterial invasion across the lymphatic system. That is acute infectious lymphangitis. Um, the next condition is a skin cancer that has like the ugly duckling sign, so the lesion doesn't look like the ones around it. It might be asymmetrical, has multiple subtypes, including superficial, nodular, lentigo, acrolentiginous subtypes, and that would be melanoma. For this, the recommendation is do an excisional biopsy with 1 to 3 millimeter margins. And then if breast low thickness is 1 to 2 millimeters, then the single lymph node biopsy must be added. Melanoma excision guidelines. Okay, the next condition is going to present with telangiectasias and the lesion looks pearly. This is the most common type of skin cancer, that is basal cell carcinoma. The next condition has actinic keratosis as its precursor, presents as a keratinizing lesion with a central ulcer, that is squamous cell carcinoma. And then yeah, so I want to go back to the melanoma. It says excisional biopsy with 1 to 3 millimeter margins. It should be 1 to 3 centimeter margins. And the guidelines for those are like it's also like kind of rough, but it is like pretty wide margins, and then also the breast thickness being if it's like anything over stage 2, I think this is what that is. Excising with the single lymph node biopsy is good. Um, a patient presenting with inflammation of the dermis and the subcutaneous tissue, that would be cellulitis, versus the infection spreading across the fascial lines is necrotizing fasciitis. A patient that presents with a spider bite that has like a small bite that grows bigger and bigger and bigger, that would be a brown recluse bite. Um, that's like the only spider I keep seeing, but I'm sure there's more. And the management tip for this is just supportive care and then debridement once the demarcation occurs. Okay. Um, So this is like a COMAT specific topic for sure. And I don't think like you get actually tested, but like it can help you narrow down like which organ is involved. So I've listed the sympathetic and the parasympathetic innervations here. And really quickly, we'll go through the Chapman's points that were like higher yield. So um, the fifth intercostal on, I want to say the left side, is for acid for the stomach versus sixth intercostal for motility. And then the liver and the gallbladder is the sixth intercostal on the right side along the midclavicular line. The appendix is the tip of the 12th rib on the right side. And then the descending colon is going to be like the anterior thigh along the IT band. And you can read the rest of the sympathetic and the parasympathetic innervations here. Okay, now with burns, the different like descriptions of the burns. So a first degree burn just is the epidermis. The second degree burn is going to be split up into two subtypes. Superficial is going to have the epidermis and the papillary dermis, versus the deep is going to have the epidermis and the reticular dermis. And then the third degree is going to be full thickness, and the fourth degree is full thickness with muscle. So how it presented in a vignette was the superficial second degree is like super painful versus the deep second degree is only painful to pressure. The Parkland formula is like fluid resuscitation and how much to give. So that's just going to be 4 times the total body surface area of the burn times the weight in kilograms. And out of like the total fluid that's calculated, 50% of that would be given in the first 8 hours, and then the next 50% over the next 16 hours. So to calculate the total body surface area, the rule of nines is going to be applied. So the trunk, anterior side is 18%, posterior side is 18%. The lower extremity, the whole right leg is 18%, the whole left leg is 18%. Upper extremities is going to be the whole right arm is 9%, the whole left arm is 9%, and then the head and neck is 9%. And then I think like the 1% else comes from the genitals. With kids, they have extra like percentages allocated to their head because their head's big, and where that gets compensated is from the leg. Um, with electrical burn risks that include rhabdo, arrhythmia, or posterior shoulder dislocation. Caustic burn risks, so that's like chemical burns. The alkali burns are worse than the acidic burns. Alkali burns cause liquefactive necrosis to the esophagus. And the acidic burns is the coagulative necrosis to the stomach. And I just like to think of it as like, oh, like liquefactive, you can't see anything anymore. So that's going to be worse than coagulative. Also, the esophagus is going to be like the first thing it encounters. So the more severe one gets like the more severe type, which is liquefactive, and the more severe location because it just happens faster in the esophagus. Um, with the circumferential burns, the risk is compartment syndrome. So if somebody has a circumferential burn, then the ascarectomy would be done. And if they do develop the compartment syndrome, fasciotomy. All right. MSK conditions, a condition that mimics the DVT has a crescent-shaped ecchymosis and is due to distension of the gastroc. Gastrocnemius semimembranous bursa associated with knee osteoarthritis or meniscal tears is a Baker's cyst. A patient presenting with the 6 Ps, so pain, pallor, pulselessness, paresthesia, oh my gosh, poikilothermia, paralysis, that is acute limb ischemia. Um, and management for this is heparin to stop the clot from growing more. A patient that has stiffness after trauma or procedure, this is like more of an X-ray finding and is due to benign lamellar bone formation, has heterotrophic ossification. Um, and then finally, a patient that is on anticoagulants, they might be coughing vigorously, now presents with a mass along their abdomen due to ruptured epigastric arteries, has a rectus sheath hematoma, and that just depends on like the hemodynamic stability, how aggressive you need to be with the treatment. Okay, the next section is perioperative care. So starting with airway and anesthesia, a exaggerated glottic closure is known as laryngospasm, and the treatment for this is give gentle positive pressure ventilation, jaw thrust, succinylcholine if it's persistent to help them relax. The patient who aspirates something and now has like symptoms of dyspnea, like lung symptoms, within hours is going to be aspiration pneumonitis. The differential diagnosis for this would be aspiration pneumonia, which is going to be more days after aspiration. The treatment for this is supportive versus pneumonia, you would have to give antibiotics. A patient that received an anesthetic agent, such as succinylcholine, sevoflurane, now presenting with fever, rigidity, hyperkalemia, myoglobinemia, myoglobinuria, is going to be malignant hyperthermia. A patient that might have received bupivacaine now has severe bradycardia, perioral numbness, seizure, loss of consciousness, has local anesthetic systemic toxicity. A patient that received haloperidol or other antipsychotics, dopamine antagonists, now presenting with lead pipe rigidity. And this is like more of a delayed onset, has neuroleptic malignant syndrome. So for these, first, stop the drug that's like number one first step. For malignant hyperthermia, can give dantrolene to help cool, to like help relax. And then for neuroleptic malignant syndrome, also dantrolene, but also bromocriptine, which is a dopamine agonist. So I kind of reverse that. And then some of the specific anesthetic drugs and their mechanisms, because there was a question over it. Um, Propofol is a direct GABA A agonist versus etomidate is an allosteric GABA modulator. Both of those are given IV. And then the fluorines, like the sevoflurane, is a gas allosteric GABA. Nitric oxide has many actions, including um, like modifying GABA, but it's usually used in conjunction with other anesthetic agents because it lowers their MAC, so you have to give less of the other agents. Propofol is the most common used. Etomidate has increased cardiovascular morbidity, so it's used, but yeah. Some postoperative complications. So the five W's are the five most common causes of postoperative fever. So it goes from wind, water, which is a UTI, wound infection, walking, which is DVT, and then wonder drugs. The wonder drugs can happen at any time. Also, early fever could be due to tissue trauma. For venous thromboembolism prophylaxis, the management is to do early ambulation and a lower molecular weight heparin. If the patient has renal issues, then use unfractionated heparin instead of the low molecular weight heparin. There's the medication management. So there's like a whole bunch of drugs that must be stopped before, such as like aspirin, clopidogrel, and like those anti-like platelet agents or anticoagulants, and there's specific time frames on when those need to be stopped. Also of note, I'll put it here, but smoking cessation should happen ideally 4 to 8 weeks before surgery happens. Moving on to dehiscence versus evisceration. So dehiscence is fascial insufficiency versus evisceration is the bowel actually coming out. So evisceration is the emergent surgical complication. A wound infection is treated with cefazolin if it's clean or clean contaminated. If there's anaerobic risk, then add metronidazole. With acute mediastinitis, that would be suspected if somebody has crepitus after cardiovascular surgery or widened mediastinum, and treatment is to return to OR to correct that. A patient that has neurological symptoms after lumbar spine needling, such as like a lumbar puncture, would have a spinal dural abscess or a spinal dural hematoma. Hematoma happens quicker than the abscess. A patient with recent thyroid carotid surgery, now presenting with hoarseness, has recurrent laryngeal nerve injury. A patient that underwent laparoscopic hernia repair and now has no sensation at the scrotum or the medial thigh, but has a cremasteric reflex, has ilioinguinal nerve injury versus an abnormal cremasteric reflex would have genital femoral nerve injury. With the bleeding and fluids, so if somebody gets an organ transplant, there's a high risk of infections due to immunosuppression. Specifically, trimethoprim sulfa drug is given to cover for listeria, toxoplasma, and pneumocystis. Some of the bleeding reversal agents, I'll read these out here. So aminocaprionic or tranexamic acid inhibit plasminogen to stabilize clots. That's used for like super heavy bleeding. Yeah. Cryoprecipitate contains a lot of factor VIII, fibrinogen, so that is going to be used for hemophilia A. Prothrombin complex, vitamin K, that is going to be used for warfarin. That prothrombin complex is like the gold standard reversal agent of warfarin. Idarucizumab is going to be used to reverse dabigatran, which is one of the direct thrombin inhibitors. And Dexanet alpha is going to reverse the exibans and the heparins. And then protamine sulfate is going to reverse the heparins. Um, a If somebody has like all their coagulation labs, so like PT, PTT, platelets, um, all of like those are abnormal and also they have anemia, then suspect acute DIC versus chronic DIC. It has more normal labs just because it like happens like a little bit slower. For fluid rescue principles, the 4-2-1 rule is good to know. So 4 milliliters for the first 10 kilograms, 2 milliliters for the next 10, 1 milliliter per kilogram over any like 20 kilograms. So that is like it's like 1 milliliter per kilogram per hour is the full like formula there. In terms of type of fluid, the isotonic crystalloid is the best. Hyponatremia is common due to a surge in ADH. Also, um, hyperkalemia could happen. And if that happens, then the treatment protocol is to give calcium gluconate to stabilize the cardiomyocyte membranes, and then insulin dextrose albuterol to put that potassium back into the cells. Going back to that 4-2-1 rule, if the patient is over 20 kilograms, so like in adults, the simplified formula is 40 milliliters per hour plus the weight in kilograms and that amount like milliliters per hour. So just to like simplify it, if a patient is 60 kilograms, then that would be 40 plus 60, so 100 milliliters per hour of fluid resuscitation. Um, for pulmonary and cardiac conditions, so an aortic aneurysm would be a male smoker that has sudden abdominal or back pain with low pulses. This is due to bulging of the layers of the aorta. And then treatment-wise, do a CT angio if they're stable, or if they're unstable. A patient that has hypertension, or maybe a younger patient that did cocaine and now has an intimal tear of their aorta, has an aortic dissection. Treatment for this, if it's type A, so involving the ascending aorta, um, is going to require surgery versus type B, which is just a descending aorta, it's going to have beta blockers. A patient that has a high like INR, so is anticoagulated, or maybe had a recent cardiac catheterization through the femoral artery, is a suspecting diagnosis is a retroperitoneal hematoma. This is usually like the patients are usually hemodynamically stable and supportive treatment can be given. A patient presenting with a new murmur suspect like a valve issue. So it could be mitral regurg or it could be a prosthetic valve dysfunction. Either way, to evaluate the valves, echocardiogram is good. One specific like treatment principle is if the left ventricle ejection fraction is less than 60% in mitral regurg, then do repair regardless of if they're symptomatic. A patient that has signs of pericarditis like 1 to 3 days after an MI, that is going to be due to local inflammation. The treatment is do a transthoracic echocardiogram, avoid NSAIDs, and give high dose aspirin. So yeah, like I know aspirin's an NSAID, but avoid other NSAIDs. Um, with lung cancer resection. So it is dependent on how much FEV1 and DLCO they're going to be left with. So the goal is to leave at least 800 milliliters of FEV1 and ensure that their DLCO is going to be over 40% of predicted. In specific like lung cancers, bronchial carcinoma, bronchioid, I don't know. Carcinoma is for like young people, and then small squamous cell carcinoma, small cell lung cancer, adenocarcinoma in smokers. So I think out of all those, adenocarcinoma is the most common. Um, with urinary conditions, so there's acute urinary retention. That is going to be an older male that has abdominal distension and suprapubic pain. And this is often due to bladder obstruction. So the next step for this would be abdominal x-ray or a bladder ultrasound. A patient, usually like a woman that has a post-void dribble, dysuria, dyspareunia, um, and an anterior mass, has a urethral diverticulum. Um, so differentiate overflow incontinence, which will present with a high post-void volume, and pelvic floor dysfunction, which is going to be leaking with straining, but with no mass. A patient that might have had like a long bone fracture now presents with petechial rash, fever, tachypnea, possibly shock, has fat embolus syndrome, treatment supportive. Patient that is post-op suddenly develops thrombocytopenia, that is heparin-induced thrombocytopenia. A patient that presents with non-cardiogenic pulmonary edema. They might have had a history of like sepsis, severe trauma, aspiration, pancreatitis, has ARDS. Okay, our last section is going to be trauma. So with diagnostic basics and just getting into some of the specific types of trauma, the FAST scan is going to look at Morrison's pouch, spleno-renal recess, pouch of Douglas, subxiphoid pericardial window, and to do the EFAST or like the extended one, you would add the pleural windows, and that's to check for pneumothorax. In general, for abdominal trauma, if they're stable, then do a CT. If they're unstable, CT takes too much time, so do a FAST and do XLAP if there is fluid found, and then do a diagnostic lavage if FAST is negative. And then at any point, if GCS is less than 8, then make sure the patient gets intubated. Um, a condition where there's air in the pleural space that's compressing on the midline structures is going to be tension pneumothorax. Um, the treatment is needle decompression followed by a chest tube. This is a clinical diagnosis, so there's no imaging that is needed to initiate treatment. A patient presenting with intercostal vessel injury and blood in the pleural space, dual to percussion, has hemothorax. So there would be a chest tube that gets placed, and then thoracotomy, so like open up that cavity if there is more than 1,500 milliliters on insertion or over 200 milliliters for 2 to 4 hours following. A patient presenting with consecutive rib breaks in like the same side, and might be having like the paradoxical rib movement, has flail chest. Treatment is oxygen and analgesia. A patient with fluid in the pericardial space, presenting with Beck's triad, that's the hypotension and the JVD and the muffled heart sounds, or electrical alternans on the ECG, has tamponade, and do either pericardiocentesis or the subxiphoid window to treat. A patient that was in a deceleration trauma injury, now presenting with widened mediastinum, has a blunt thoracic aortic injury. Treatment is CT angio, followed by blood pressure control, followed by the thoracic endovascular aortic repair. Um, Patient presenting with a persistent large air leak despite chest tube insertion, suspect a tracheobronchial injury, and that would need to be surgically repaired. In terms of management for a gunshot wound, it's always an XLAP versus a stab wound, would be local exploration or a serial exam, unless they're hemodynamically unstable. Blunt trauma damages in this order spleen, liver, pancreas. A bladder rupture, so can be either intraperitoneal, which will be the dome, versus the extraperitoneal structures, which is the base and the neck. And the treatment is different. If it's the dome, there will be surgery. The base or the neck is a catheter insertion, so a little more conservative. A patient that has massive bleeding that's not detected on fast um, might have a pelvic injury, so treatment for that would be a pelvic binder. A patient with pain out of proportion to exam, the paresthesia, pallor, poikilothymia, pulselessness, all of that would be suspecting for compartment syndrome. And if you suspect compartment syndrome, um, fasciotomy is the treatment. Also, I think with compartment syndrome, I've like seen it really hurts when there's like passive movement of the distal segment of the limb. A patient presenting with blood on the um, erythromeatus, a high-riding prostate, a scrotal hematoma that had recent pelvic trauma, is suspected for urethral trauma. And the most important management principle for that is to do a retrograde urethrogram before inserting a Foley because the Foley can make that injury worse. Okay, so specific blood principles. So for replacement, the target for the systolic blood pressure is 80 to 90. Except for in the case of a TBI, there's permissive hypertension. You want to keep that blood pressure high enough to perfuse the brain. Um, the goal is to limit crystalloids and initiate mass transfusions if the patient needs more than 10 units of packed red blood cells in 24 hours. The lethal triad is going to be hypothermia, coagulopathy, and acidosis. And if any of those like happen in the OR, then they must be stabilized and corrected medically before re-entering the procedure. The different classes of hemorrhagic shock. Grade 1 is less than 15% of blood loss, so anxiety but normal vitals. Level 2 is 15 to 30%, so there's tachycardia up to 120 beats per minute, but normal blood pressure with decreased pulse pressure. Level 3 is 30 to 40% with tachycardia up to 140 beats per minute. There will be hypertension or hypotension. And level 4 has more than 40% blood loss, tachycardia over 140 beats per minute with hypotension. The different types of transfusion reactions. So I think the easiest way to think about it is like how long it takes. So with anaphylaxis, that's like immediate due to an IgA deficiency. Treatment is IM epinephrine. For the acute hemolytic, that is due to ABO incompatibility, this happens in minutes. A clue is dark urine because there's intravascular hemolysis going on. Treatment is IV hydration. Um, Patient presents with, so the next two are like the lung damage injuries. So trally happens due to the donor plasma um, attacking the lungs. And this happens within minutes to 6 hours. There is no signs of circulatory overload. And that's an important distinction from TACO, where circulatory overload is the mechanism of the lung injury. And then the final one is the febrile non-hemolytic reaction, and that is due to cytokine accumulation. And this will have no hemolysis symptoms and no lung infiltrates. Okay, finally, there's just like a small section on like quality control and safety. So with quality measures, the structural processes are like the framework or the capacity of the system. Process is activities that's provided that is done by the providers. Outcome is the intended effect versus balancing is the unplanned side effects. With safety measures, some of them that were mentioned is to flatten the hierarchy. So like anybody should be able to bring up a safety concern and then closed loop communication, repeating back what you just heard. QI initiatives. So the four that I saw was the first one is an FEMA, which is a failure effects modes analysis. So in that one, you're trying to see like what could possibly go wrong in the system that we have created. And then the next one is a PDSA or a plan, do, study, act. And that's just like a trial of like a new safety initiative and see if that works on a small scale before implementing on a large scale. So those two are proactive measures versus retroactive measures. So an RCA is a root cause analysis. Once an event happens, analyze like all the system factors that went into why that bad event occurred versus human factors analysis is similar to a root cause analysis, but now you're just focusing on what were like the human factors that are involved in the causing of the event. Okay, I think that's it from me. This is my first one, so um, you can let me know if you want to see more. Um, but yeah, thank you for listening. Bye bye.